An edition of the Office of Nursing Research's Research Roundtable. So I know all of us have been hearing a lot over the last few years or so about the Nell database, and I'm happy to tell you it's finally here. So we have the masters of the Nell database with us, Rose Hayes and Andy Plotzky, and both of your titles escape me at the moment, so I'll let you guys tell everybody what your titles are, and then I'm sure you'll be explaining what your role is with the Nell database. And this is such a it's been such an undertaking, so exciting, and such an opportunity for us that I can't wait to hear all about it. So I'll let you guys take it away. Thank you.
Andy, do you introduce yourself first, and then I'll introduce myself and jump in.
Okay. All righty. I'm Andy Plotzky, and I used to be part of ONR, so I feel like I'm like kind of back home. But I wanted to tell you, I am the project lead for Nell, and I'm the database architect. So we also have a programmer who works with us, but he's not on with us today. I didn't mention this to him. But anyway, he's busy programming, getting everything ready and finished up. So because we're currently loading data now, or finishing touches on the data. So that's me. I have a background in public health and informatics. And we have a great team of people that I work with. There's Judy Katz is there, and Rose. So go ahead, Rose, and you can introduce yourself.
Sure. Hi, everybody. Thanks, Drenna. Thanks, Andy, for the intro. I'll go ahead and do a screen share. So my name is Rose Hayes, for those of you who I haven't met yet. I am the director of engagement for the school. So that includes working across a handful of different projects. And one of them is Project Nell. So I've been working closely with Andy, Judy, Masato, Vicky and Roy, and others to get the word out about Project Nell and increase engagement surrounding this project. So our presentation for you today is a little bit broader than Nell, though. It kind of positions Nell within this conversation about how to be a nurse innovator. And it does, we are going to explore other tools and other resources being developed at Emory to facilitate innovation work, especially for nurse researchers who want to apply their research towards innovative products, processes, and solutions to improve healthcare. So I am going to turn off my video, though, because I tend to have better luck with the presentation bandwidth when I do that. So bear with me. And I'm going to open my notes here. Okay. So I'm going to share some slides to get our conversation started. We'll go into, like I mentioned, these different resources. We'll talk about Nell, give some Project Nell use cases, and then Andy will give us a demo of Nell, give you all a sneak peek before we open this up to conversation. So at a very high level, we know that whenever there are big problems in healthcare, from emerging threats like COVID-19 to long-standing problems like health system inequities, if you want to find a precise and effective solution, you should probably ask a nurse researcher how to fix it. Because the nurse or the nurse researcher has probably already come up with a workaround solution or a makeshift prototype for their own practice area that could be patented, scaled up, and used to improve healthcare across the system. But the problem that we see over and over again is that most nurse-led solutions never leave the dreaming or the prototyping phase, or they never impact patients beyond a nurse's own immediate research group or immediate practice assignment, because the innovation process can be really hard for anyone. And those challenges are compounded for nurses who are usually doing everything they can just to keep people alive right now. You know, most nurses are working with limited time, money, resources, and infrastructure. Did I lose you guys?
Mm.
No, we see you.
You're fine.
We hear you.
You're fine.
Okay. That's weird. It looks like it's just my presentation and no Zoom. So let me know if you lose me or if it gets glitchy. So like I was saying, most nurses are working with very limited time, money, resources, and infrastructure, let alone a roadmap to reinvent the system that they work in. And then there are very real barriers to innovation for nursing on top of that, which we are going to talk about in a bit. But it doesn't have to be that way. We believe at our school that we can create the mechanisms that nurses need to lead patients and colleagues into the 21st century. And that includes upskilling nurses of all levels in core innovation tactics and skill sets like design thinking, informatics, and data science. And this mentality really sets Emory Nursing apart. It's helped to push our school to the top 8 DNP and top 2 master's program in the nation. And it really has played an important role in securing our health system's magnet designations and rankings. And this unique way of thinking about problems runs across our organization. When an Emory nurse comes up against a roadblock to good care, they don't just look for workaround solutions like many nurses in other health systems have to. Emory nurses disrupt. We move across professional boundaries, bring together people and communities to improve things for all nurses and all patients. And this really helps to drive the whole system forward. And we don't work alone. And that in itself is critical to being successful in this space. So for instance, our academic practice partnership with EHC helps us to be closely aligned with the health system and understand its needs so that we can be knowing the right research questions to ask, knowing where practice is falling short, so that we can respond to that with the right intervention studies and things like that. And we can be preparing students for the current and future realities of the health landscape. And that's not just in terms of filling spots on understaffed units, but in terms of nurses' ability to think critically about issues on those units, ask the right questions, and lead research in their practice areas. So if you have a problem that you'd like to tackle, we do like to encourage people to think about the types of allies you can recruit who can share in your vision for solving it. Because you're not going to do it alone. Disruption is inherently interdisciplinary. It takes a team. Using Project Nell as an example, we were able to convey a clear narrative for the problems we were solving and create a shared vision with partners like the American Nurses Informatics Association, Goizeta, IBM, and others. Who have helped us to bring Nell to life through things like focus group, market analyses, and the development of educational materials. We tend to think about funding relationships first and foremost in nursing research in academia, but there are other ways to ask for and leverage help and create your own little army of change, especially when it comes to leading effective research and in the innovation space. And this is so important because when it comes to innovation work, nurses really are up against the odds. From gender-related glass ceilings, which persist across sectors and are compounded for women of color, and the fact that nursing remains a predominantly woman-identified workforce. So for instance, only 12.7% of inventors named on patents are women. Most patent applications are developed by teams, and the gender makeup of these teams is incredibly imbalanced. So according to the UK Patent Office, just 0.2% of global patent applications come from all women teams. And then on top of that, you have nursing's decades-long attempts, and in many cases failures, to catch up with competency and curricular standards in innovation. The 2021 AACN Essentials and the 2021 Future of Nursing Report are just the most recent in a long laundry list of calls to educate and upskill current and future generations in innovation skills like informatics and data science. And yet we see deeply rooted barriers in this area persist, like the need for diverse people power to tackle problems, the time to learn new skills and teach others, the costs associated with most tools on the market, accessibility of data, and outdated assumptions about what it means to be innovative. And the issue of culture change is a big one. And it's one that we could probably do a whole presentation about. And when you're talking about nursing research in particular, it's, a big barrier is the fact that nursing emphasizes the need for evidence-based practice, right? But nurses often don't tie real-world health systems data into EBP, and they often aren't even encouraged to. Many grant applications, many proposals for advancement in the health system will require lit reviews or deep dives into the literature. But very rarely do you see people saying, show me your data, show me your real-time, real-world data from the health system. And in reality, those two things are no longer separate. Effective EBP is data-driven. Data science as a skill set is no longer peripheral to nursing, but actually integral to all levels of competent nursing care. And that's why we are so focused on creating accessible nurse-designed mechanisms to drive innovation and make data science easy to understand. And there's no question that this is all a nursing need, right? Everyone recognizes nurses need to be upskilled in innovation competencies like data science. The question is mainly, how do we get there? And for those people who can persist in acquiring these skills, the nurses who can learn these skills and apply them despite everything, for those people, the payoff is big. The jobs in this space are waiting and there are not enough nurses to fill them. 50% of healthcare organizations are in the midst of digital transformation strategies, and they're looking for nurses who can lead research that reflects clinical problems, nursing leadership principles, and big data. In fact, 32% of healthcare organizations have created chief nursing informatics officers, and we are going to see this role become increasingly more commonplace. And year after year, we see the HIMSS Nursing Workforce Survey tell us that nurses with informatics and analytics skills are more marketable to employers, they're higher paid, and they receive more job offers than nurses without these skills. And yet supply versus demand in this area remains unbalanced. So what are we doing about it at Emory? The fact that we are creating resources, tools, and structures to propel nurse-led innovation, and the fact that we're making them available not just to our students and faculty, but to nurses across the health system and beyond, is disruptive in itself, because access to these types of tools and mechanisms has been a problem for our profession for so long. And our willingness to listen to nurses' ideas, excuse me, and support nursing solutions has really been instrumental when the going gets tough. It's enabled us to be agile and not just responding to crises over the years like Ebola and COVID-19, but actually leading the national response to these crises, because we do so in an innovative manner. So the following items are just some of the tools and resources that we are developing to make innovation possible for nurses at Emory and beyond. But certainly the resources at Emory are not limited to these items, and I'm happy to talk more about courses, resources beyond the School of Nursing, things like the hatchery, et cetera, that we can also leverage when doing nurse-led research in the innovation space. So the Emory Nursing Learning Center is obviously still under development, but it's coming soon to downtown Decatur. This is the place where nurse-led innovation is going to start for Emory nurses. It's a 70,000 square foot hub for nurses and collaborators from different disciplines and sectors to share in knowledge and discovery and come up with interdisciplinary solutions. Within the ENLC, we are planning and developing an innovation hub, augmented reality and virtual reality rooms, an interactive apartment to practice home and hospice care, which we're especially excited about, interdisciplinary collision spaces where nurses can meet and think with people from other disciplines in a casual manner, like over Legos and coloring and things like that. And of course, smart connected classrooms and labs, which people can access from anywhere in the world. Within the Emory Innovation ecosystem, which includes several centers, like I mentioned, the hatchery and the main Emory Innovation Hub, our innovation center is going to stand out by bringing the engineering, business, and practice perspectives together in one place. So we're going to be a place where people can actually build and do things to execute the entire life cycle of patient and community-centered innovation, including prototyping and testing. And this was important to us because Emory, as you know, doesn't have an engineering school. So we wanted to be able to welcome partners like Georgia Tech, IBM, and GBS into this space and provide material assets for hands-on creation. So again, this is still under development, but we can't wait for it to come to life and be available to everyone. Many of you are familiar with the Center for Data Science, may have worked with the center already. CDS was established in 2015 with the hiring and recruitment of Dr. Hertzberg. And it was built to bring the power of data-driven thinking to bear on the greatest challenges in healthcare and scientific discovery today. Some of the services that you can access through the center include, but certainly are not limited to, gaining access to downloadable healthcare data through Project Nell, access to and mentorship on how to analyze and apply omics data, the means to create, patent, and learn from real-time biological and environmental sensors, and professional support to develop and protect nurse-designed ideas. Next is Emory Nursing Experience, which is increasingly moving into the innovation space in partnership with Project Nell. E&E is our nationally accessible catalog of immersing continuing ed courses. E&E courses are heavily informed by data and insights about workforce gaps and needs from EHC. And courses are taught by faculty experts and complemented by virtual, in-person, and hybrid opportunities to actually apply that knowledge and leverage it in your research. And you can access contact hours and certifications in new nursing skills from anywhere in the world through E&E. And then, of course, there is Project Nell. And Project Nell is really at the heart of our school's vision and mission to cultivate a workforce of digitally enabled nurse disruptors. It's the cornerstone or starting point for innovation work because to solve any problem, any healthcare problem in a precise way, you really have to start with the data. So what is Nell? It's a suite of apps for teaching, learning, and practicing nursing data science. It includes searchable healthcare records that any nurse can use and download, even if they don't know a lot about technology or data, even if it makes them a little nervous. And it contains teaching and learning apps that are being carefully curated to make sure it's easy for nurses to understand and use data in their research. And so with these features, Nell introduces a sustainable solution to many of these bigger problems we've been talking about. It solves for the often overwhelming frustrations of trying to access and organize the data you need for your research in the real world. It makes data fast, easy, affordable, accessible. And it gives you those supplementary teaching and learning tools you need to use these data if you're not familiar with data science. Real quick, some of the things Nell lets you do if maybe you're less familiar with it. You can measure and show nursing's impact on health systems. Like I said, learn and teach data science. Explore nursing sensitive data among many other types of data, including national quality indicators, and apply these insights to streamline processes, work faster, cut costs, and reduce disparities, among other things. Nell is growing and evolving constantly. It now contains 2.7 billion searchable records from across Emory health systems, representing 1.2 million patients. That covers 15 million encounters, 37 trillion data points, and counting. So I am going to run through a few quick examples of how Nell has been used in nurse-led health system transformation work and research already. And then Andy will give you the sneak peek. But before I do that, I do just want to ask the group if there's anything they would add or correct at the Project Nell group that's on the line. So if Andy, Judy, or Vicky has any corrections, please feel free to weigh in.
Sounds great, Rose.
So far,
as always.
Perfect.
Nothing to add.
Yeah, no, it's great.
Great. So if anyone was on the staff meeting, you heard some of this already, so forgive the repetition, but we do feel it's important to share examples of how Nell is used so that you can really wrap your heads around like its real world applications in innovation work and research. And then you can think about, well, how can I use it in my research? So
Project Nell is the epitome.
I'm gonna start with Jasmine Nakayama, who many of you probably know. Jasmine was a Robert Wood Johnson Future of Nursing Scholar. She graduated in 2019 and is now working as an epidemiology officer and fellow for the CDC. While she was at Emory, Jasmine used Nell to inform her dissertation on hepatitis C, and she contributed to Nell's development. So I'll let you hear from Jasmine briefly before we dig into her research a little bit more.
Project Nell is the epitome of sharing care. It allows nurses, community leaders, and others on the front lines who have an idea or notice a problem to have the resources and data that they need to create a solution.
So this is a closer look at Jasmine's research. All of the abstracts in this slide deck are partial abstracts, and the dots indicate that text was cut to fit it on the screen and make it readable for all of you at a glance. If you want to see the full abstracts, just let me know. So Jasmine looked at factors impacting the progression of care for baby boomer patients with hepatitis C, including demographic and clinical factors impacting their average age at first screening, whether they were connected with appropriate follow-up upon screening, whether they received correct and timely care upon diagnosis, and whether or not they were able to progress to a cure. Some of the predictors she looked at included gender, race, ethnicity, insurance status, comorbidities, and others that you can read about in her publication that's cited here. And her research did reveal important differences in care, especially surrounding demographic characteristics. And she offers data-informed recommendations for her readers on ways to fix those differences in her paper. Here are some photos of Jasmine presenting a couple of different data-driven research projects that she completed through the Center for Data Science while at Emory. Next, we have Bette. Bette is an Emory, Ethiopia PhD in nursing student. She used Nell to determine which comorbidities were most likely to predict death among patients with pressure ulcers. So she looked at records for patients with pressure ulcers across Emory systems from 2012 through 2014. And what she did was she cross-referenced factors like age, race, gender, and people's comorbidities to see which patient profiles were most likely to have a pressure ulcer progress to death. And sure enough, she validated her hypothesis and found that dementia and malnutrition were significant predictors of death for these patients. Next up, we have a word from Bette about what working with Nell meant to her and what she believes it can mean for other nurses and patients.
Hi, my name is Bette from Ethiopia. I'm a PhD student at Addis Ababa University in collaboration with Emory University, Nell Hodgson Woodruff School of Nursing. I'm here to say or to speak something about Nell project. Nell is a revolution for our profession. The reason behind would be, first, nowadays we are in the midst or in the center of data revolution. Second, COVID-19 also showed the world that the future of the healthcare is data-driven and nurse-led. Then, third, Nell itself is making it that nurses, wherever they are, can take the matter into their own hands and can lead the data-driven health system to change the front line and can get the insights they need. Thank you.
Next, we have Emily Newell, who was an honors BSN student. Emily's project is important for several reasons, including the fact that she was an undergraduate, which highlights the most important aspect of Nell, which is that it's made to be easy and accessible, no matter your education or career level. Emily worked as a care tech in the MICU during her time at Emory, including at the height of COVID, and she's now working as an RN at Johns Hopkins. And she was able to secure this high caliber role thanks in part to her scholarship and publications as an undergraduate, which were informed by her experience in the MICU, her intuition as an emerging nurse, and her access to big data. So after Emory made changes to the TAVR procedure, which is the heart procedure that Mick Jagger famously had done, Emily felt a need to better understand the factors influencing outcomes, including adverse outcomes surrounding these new approaches. So for patients undergoing this procedure, she looked at types of anesthesia, anesthesia provider type, patient eligibility, and other factors. She cross-referenced those with bad outcomes like acute kidney injury, vascular leakage, and the need for a permanent pacemaker. And she was able to see the factors that put patients at greater risk for poor outcomes. And she did this so that the patients she was seeing and treating every day could have more optimized and personalized care plans and the best possible chance of making a Mick Jagger kind of recovery. In terms of implications for nursing as a profession, Emily's research also revealed a cost benefit associated with having a nurse anesthetist perform this procedure, which is really phenomenal because we're always trying to demonstrate the impact and value of nursing to healthcare. So next we have a word from Emily. This video mentions nurses' notes, and that feature is coming soon. It's going to be part of phase 2 of Nell's development, the ability to search nurses' notes. And because Nell is growing so quickly, the data counts in this clip are actually outdated now, so just keep that in mind.
Nurses make observations all the time. Nursing is all about assessment and observations. And intuition is when you have a hunch about maybe something broader that might be happening. I'm an undergraduate student pursuing my Bachelor's of Science in Nursing, and I'm an honors research scholar. My research is focusing on transcatheter aortic valve replacement and looking at the exact quantitative cost savings to have a nurse there watching, monitoring the anesthesia. If it weren't for Nell, my project would really be unrealistic because I only have a 2-year period to gather patient data.
I developed Nell to give nursing students, nurse researchers, nurse faculty, and other nurse scientists access to big data in a setting that's meaningful to them. Nursing nodes are where the real rich data is. What makes Nell different from other software is the fact that we're using these nurses' nodes and being able to delve into them.
We believe that those nurses' nodes have salient information to inform practice and keep our patients well.
I'm really excited about Nell because it allows students to affect change on a system-wide scale. With access to this database, we can make observations and make research which would potentially save lives.
And then last, we have Taylor Cortner. Taylor was a member of the inaugural nursing anesthesia DNP cohort. She looked at the differences in opioid administration among breast cancer patients undergoing mastectomy according to race, age, and location. Her research exposed several disparities in care for people with breast cancer, including the fact that white people received an average of 7 more MME than Black people. Patients ages 50 to 60 years received an average of 25.97 more MME than other age groups. And there were significant variabilities in opioid administration practices from location to location across the system. So all of these projects we've talked about are highly unique and dynamic. Together, they show how easy it is for students to use Nell and faculty across career levels and cohorts, and how even within these different nursing fields and specialties, there's a wide variety of ways to leverage this tool in research and in innovation work. So I'll stop there and hand it over to Andy for her demo, and then I think we're going to do questions at the end. Thank you.
Okay. All righty, thanks, Rose. That was great. Okay, so now you know what our end game is. Let me just show you a little bit about the process. So, so as mentioned in that film, Vicki Hertzberg really was the brainchild behind Nell. She started with the idea of let's build a data, let's provide a mechanism for data sets to be available to our students for when they need a data set to work with. And also, of course, researchers have heard about this. So our faculty researchers are also pretty hot about Nell being available. So, so that was the original mandate. And originally it was going to be 20,000 patients. But here, I can show my video. So you can actually see me as a person. Okay, so anyway, it was 20,000 patients. But what we realized is when you were working with some of the data that was for problems or things that were not very prevalent, then you ended up having too small of a data set. And so push came to shove and someone kind of challenged us and said, well, why not have 1 million there? And all of a sudden it went from 20,000 to 1 million. We thought about, let's do 100,000. And then this guy said, no, do 1 million. So we're like, oh, okay, sure, we'll do 1 million. So that's what we've done. And so we have 1 million patients in this database, and that represents their interactions with the Emory healthcare system from 2012 through 2019. So everything is HIPAA compliant. Everything is, it's set up so that we don't have real dates in there. We have the dates are relative to each other. So if someone's first visit is on a certain date, We can shift the date by up to 365 days, but then all their other visits after it will be relative to that date. So you really can get a good idea of lengths between interactions with the healthcare system and length of stays, for example. So everything has been done to the top HIPAA compliance that is possible, and that's probably because the data warehouse, who is where we get our data from, they are really sticklers for that. So we weren't able to get data. There's some places where we wanted data, but we couldn't get it. And that's part of our holdup with the nurses' notes, is that it has real dates in it. It might mention some people. So we have to clean that of the private health information that's in those notes before we can release them. But we still have plenty of data points that are around that we can, work with. So the idea of Nell is that to make it simple. So that was my mandate, is to make this a simple system so that nursing students or researchers who are busy learning about the medical side of nursing don't need to also become database experts in order to be able to get a data set. And then the other part of it also was that we wanted to make it just very practical. So we wanted to have it so that we can provide the data set easily, and then it can be downloaded, and then it can be taken to whatever other software you want to use to do further processing. So you can open it up in Excel, you can take it to SPSS. Those of people who are more advanced could take it to SAS. So you can do whatever you can take that data set. It's just a CSV file that can be taken wherever, whatever you want to do further processing of it. We've cleaned it pretty well, but we left some things in there that are a little bit dirty, because we want students to learn that data isn't always clean. So, we're going to be developing curricula around these data sets. We want to make sure it's not like too squeaky clean, because when you get data, it's never squeaky clean. You got to make it so it's, so it's realistic. So I'm kind of short on time, so let me go ahead and just get right into it, okay? So I'm going to share my screen, if I can get my cursor here in the right place. Come on, cursor. Oh my, here we go. Okay, so I'm gonna close this. There we go. Can you see the screen? Maybe
yes.
Not. Okay. Yes, you can see the shared screen. Okay, I'm closing my laptop now, so we can see this. Okay, so you can see. Okay, so right now this is like the opening screen. There actually is a login process that people will go through. I've kind of skipped over that for this. And this version right now that I'm showing you is our demo version. So it only has 100,000 patients in it at the moment, but we have our million one. It took us forever to get this data in and get it indexed and all, much longer than I expected. I'd never worked with this amount of data before. So it's really been a process. So the first thing that it shows right here is our data dictionary, which we're quite proud of. So we took this data set, and the first thing we did was look at what's in there, because we were handed data tables. We had no idea what we really had, because a lot of the names of the variables were not things we recognized. So first of all, this is a listing of the various concepts that we have represented in the database. I'm going to call them tables now, or collections. So we have hospital encounters as well as clinical encounters. We have administered medications as well as prescribed medications. We have surgery information on anesthesia and surgery. We have microsusceptibility labs. This is loaded twice actually, and then regular lab values. We have CPT codes in there for hospital as well as clinical items. There's orders. We have a diagnosis table. And then of course we have patient demographics. So, and then there's this big behemoth called Power Forms, which actually will have a different name, but that's basically all the non-lab related tests that there are. So it can be blood pressures, weights, a note about the person has a caregiver at home, just little, it's like 21,000 different items that are listed that are in Power Forms. So, depending on what the situation is, you have admission, intake information, just all kinds of things. It's just a plethora of information. So we're working on getting that organized now because it's kind of a bear to work with. So everything we have is defined. And then if we go here, you'll see our list of fields. So we can look at what we want to see. So right now I don't have anything clicked here. So I can search for something. So if I want to know, well, I wonder which of these tables has information on the age, for example. I want to know the age of my patients. You can go to this little search box here and just type in age, and it'll bring in everything that has the root AGE in it. So you can see there's all kinds of things here: age calculation, age ranges, dosage, because it has AGE. So this isn't like a perfect little thing. It's just using those letters, AGE, but you still can get to age at encounter. And you can see here that it's in the all encounters table. Then you can go click on that all encounters table and see more about that. But everything we have always gives a definition. So we can look at it this way by searching for a particular concept, or we can just go to the table and say, for example, let's go to this diagnosis table. Oops, I'm going to take age out of here because there's nothing in the diagnosis table. And then it lists everything that's in that. And you can see that the diagnosis information, there we go. Let me do that again. There we go. There we go. So it lists everything that's in there. This is the name of the field. And then it gives the definition for that. So you know what that data represents. And we've changed some of the names here to be a little more user-friendly. So if you wanted to see, for example, let's say you said, well, diagnosis ranking, what does that mean? You can read the definition here, and it says a diagnosis was considered primary or secondary. And you can click this little plus sign here, and you can see, like, what are the choices? This is what the data actually is. It'll have some things that are null, which means they're empty. And actually in our final, this probably won't even be listed here. And there's things with primary diagnosis or secondary diagnosis. You also could look at like the scope of diagnosis. This one we haven't loaded here yet. So we're in the midst of getting this data finalized to load in here. But we have a finder for diagnosis codes. It's real easy to use. And anyway, this is just a tool to use. You might use it at the beginning when you're starting your research to know where is the data that you're particularly interested in. You also would probably make good use of it after you've gotten your data and you have a field and you want to know, well, what's in here? And you can see that these will list, all of these little pluses will be populated. So you'll be able to see what are the possible items, values that there are in that field. So that's the data dictionary. And we kind of preceded Emory Healthcare with getting a data dictionary of this data, which is interesting. They had an old one, but they didn't have anything recent, and we didn't have anything that had what the possible values are. So one thing we came up against was the fact that Emory has had a number of acquisitions over the years, and everybody's healthcare record is a little bit different. So we had to kind of harmonize those. So I'm going to go back here and get back. Here's a little movie again. And then here is actually Nell. Drum roll, please. So it's opening up here. So this is what you will work with. Just click on this, try it now. And you jump right into the data selection. So, we recommend that people spend a little time before they start thinking about what is it I'm looking for, what's the best way for how I'm going to find it, where is it going to be. So you have to do your homework a little bit before you get going on it. So you know what you really want to do with it. But anyway, after that, then it's just kind of a piece of cake here to select what you need. So I'm going to expand this. So the first thing it asks is, what years are you interested in? And this data set only goes through 2018. So I'm going to just say here, 2016 to 2018. So you can slide it to what you want. Our hunch is that people really are interested in the more recent data, and there will be some that want to do big data sets. But what we found is with this 1 million patients, it's very easy to come up with thousands of encounters that meet your criteria. And it's probably more. Most students probably want 100 or 200 data records to mess with. So we're kind of limiting these to the more recent, make it a little easier. And then we have what are called our pathways. So 5 of these are developed. Actually, these are developed as well in our final one now. But these are our pathways. This is where if you know a patient ID, and these again are de-identified patient IDs. But let's say you've researched something and you want to go back in and look a little further for this patient, you can put in just their ID here. An encounter ID would be another one. So an encounter is a visit. And of course, as we said, there's clinical visits and there are hospital visits. We have demographics, and then we have diagnosis, and we have procedures, medications, and labs. So those are the ones that are developed fully now. I'm going to show you, I'm going to just have a scenario here where we're looking at diabetic patients, let's say. So I'm going to click on the diagnosis pathway, and then it comes up with the questions that we predict are the most logical ones that people are going to ask. So the first thing is, do you want a simple diagnosis or do you want a comorbidity? So I'm going to just say simple, since we're on kind of limited for time here. Do you know which codes you want to search for? So these are going to be Icd-9 and Icd-10 codes. If you don't know the codes, you can just say no here. And then you get this nice little selection box here. So I'm going to look for Icd-9s, although I could look at for Icd-10 since it's more recent data. But I'm going to just go in here and start to type in diabetes. And it immediately drops me down to everything that has the word diabetes in it. So I can just put that root as well and get including diabetic as well. So it just depends on what you're looking for. So I'll go back to this. And if you look here, you can see these are the Icd-9 codes. So this one says 250 for diabetes mellitus. And if it is just a plain whole number like that, then it will automatically scoop up everything that's down below it with the 0.5, 0.1, 0.2, 0.3. So these are listed in alphabetical order, not in numeric order. Let's say I want to pick up that whole section, and then I can just scroll down and see what else there might be. And I can see here, there's diabetes mellitus complicating pregnancy. So I'm like, oh, that's interesting to me too. So I'm going to click that one. And then, I can go down and just pick whatever I want. But you can see these 250s are picking up all of these 250s that are here. So I'm going to just go with those for right now. And then I can go now to ask if I want certain CPT codes. And I'm going to say no right now so we can get this show on the road. And then diagnosis type is the other part. So as you may or may not know, when you look at an electronic health record, there are many different types of diagnoses. So there's the working diagnosis for when someone arrives at the hospital or whatever, and there's like 3 possible diagnoses. But oftentimes with an admitting diagnosis, there's a whole list of items that the person has wrong with them. So these can be quite extensive. So you need to figure out which is the one that's more relevant for what you're doing. So if I want to look at some inpatient data, so I'm going to say admitting diagnosis, and then I'm going to look also at discharge diagnosis, and might as well do billing too. That'll give us a good idea of what's at the end. And then I'm going to start my query. So all of this is where you've put in what you want to look for. And then the system will come back and show you how many patients and how many encounters there are that meet that criteria. So right now it says there are 611 matching patients and there's 1,718 matching encounters. So if that's a good number for you, you can go in and do it. If you really were hoping to get 1,000 patients, you can go back and try to broaden your search. But of course, in our million database, you're going to come up with 1,000 easily. So I'm going to just hit hospital encounters here. So these are other things I want to see for those patients that have been selected based on that criteria. So I've got my diagnosis already automatically gets checked, hospital encounters, and then I'm going to do patient demographics. And then I'll just say confirm. And so oh wait, and it should bring up the data. There we go. Okay, so now we can see we've got our tables here, and it lists these 3 that we requested, and then it also has one called All Encounters, and that just has little basic information. It has like the date of the encounter, the age of the person, and their insurance status. It's just a little bit of data about that encounter that's common to every encounter. And then we have these other ones. So if I want to look down here, and next thing is graphical summary. I can see a graph. Let's say I want to look at their ICD. Whoops. Let me switch this. I want to look here at the diagnoses. So I want to look at their ICD-9 codes, let's say, since that's what I was selecting. And it comes up with this graph showing me a whole bunch of stuff here. So the first ones, you can just slide over it and see what it is. So that's my number 250 there, and all my items. But then number 2 is unspecified essential hypertension. So you immediately can see some comorbidities here. Since they're difficult to read here with the graphics here, because there's not really room, you also can get a frequency summary of that. And so I'm going to choose the same thing here. I'm going to say ICD-9, and then it gives me this same data that's here, but it lists it in order, numeric order, from the counts, top of the counts to the less prevalent. And also, actually, in our final one, we actually have we'll have the ICD-9 code here along with the definition. So you can explore that. So all this is for the purpose of being able to check this and say, oh, is this what I'm looking for? Is this the data I want? So you also can look at it in table view, which gives you all of the diagnosis table, since that's what we're concentrating on right now. And you can see, if you look across here, it's all the various data points that are available in this diagnosis table, including like the type, the scope of the diagnosis, what the ICD-9 and 10 codes are. And then let me pull this down a little bit more. You can go over here. So you can also see that we have the scope, we have the source, well, the source of the data is probably not that important to anyone. The service date, the timestamp, and then the location, which would be actually a de-identified location, but it'll tell what the type of location it is. And then we also have MSDRG codes here, which will show if the person is an inpatient, it'll have an MSDRG code that shows what the reason for the inpatient was, the reason for admission was. So we've got that. So you can look at this and say, oh yeah, that looks like what I'm interested in. You can also you can sort on any of these. So one thing I need to point out is that every single one of these tables has the encounter ID and a patient ID, except for patient demographics, which only has the patient, of course, because it's generalized over everything. But you can connect all of these tables to each other when you take them to your next stop and you want to relate these tables to each other and you want to expand them. So you put the diagnosis alongside the demographics, you can just relate it by encounter ID or by the patient ID. In this case, it would be the patient ID. So everything will relate to every other table without having to have any intermediary tables. Those of you who've had that nightmare know what I'm talking about. Anyway, so we can look at these and then we can go back and you can explore all the other ones as well. We can look at, hospital encounters. We can see what are the, what's the type of hospital encounter people have. So you can, again, you can go down here and say, we can look at encounter type, what's in the encounter type? So we can see this many were inpatients, this were ambulatory, observation patients, emergency, etc. What was the admission type? You can see where the admission came from, emergency, elective, or urgent. So you just can explore this data and see if it's what you want. Then next stop down here below here, it gives you, in case by the time you've gone through all this and looked at it and made your notes and all, you don't remember what it was you were searching for to begin with. We give you that information right here, and you can copy that and paste it in whatever you want just to keep track of what you've got here. And then you can also download the data. So right now I have the diagnosis table up. So I'm going to look to download the diagnosis table, or I can pick whichever one I want. And then it will display for me all the fields that are possible. So you can download the whole table if you want, or you might just be interested in a few of the items. So you just go down there and say, well, I really only care about ICD-9s. I'm not interested in ICD-10s, or, you know, I don't care about the data source. I only want to know, you know, what are the MSDRG codes for it, for example. And you can select all or deselect all, whatever, to make it simple. You can look at the diagnosis ranking to see if it's a primary or a secondary diagnosis. And then the last thing that I asked you is how many patients do you want to have? So if you're a student who really doesn't want to get overwhelmed and you only really want to see 100 patients, you can just move the slider over like that. Or if you want to see all 611, you can move the slider all the way over. So we'll, you know, let's say you're on 250 here, roughly 248, and then you just click download, and it downloads to a CSV file, which you can then open up. Let's see, let me move it over here. It's coming. Hold on, I have too many. Yeah, I don't see it. Hold on. Maybe I should have had my computer open. Let's try this one more time. Let's download. I've never had a problem with this part. Well, poo. Let me find out. I might have too many things open on my desktop. Ah. Well, okay, here we go. Let's try this one. So it's showing me that it's opened at 7 times. So let's see if where it is. Not there. Maybe let me look here. To Excel. Anyway, I don't see it here, which is really weird. But anyway, it will download. I promise you, it will download.
Why don't you just, maybe you can just talk through what happens with what they can do with the download, and then I think we might have only about 2 minutes for questions.
Right. Okay. So the download will open and it'll look something like, oh, do I have one even open? I don't have one. But anyway, you'll have the download and it'll just be an Excel sheet. And when you open that up in Excel, it gives you all the columns that you requested. And then you can just take it and save it and use it in whatever you want to do your later analysis. So, you know, you can filter it and look at what the possible items are, the values that you have. You can sort it. You can do whatever you would normally do, but it gives you that data set. That's the big thing, is you get that data set, and it's a few clicks. There are some of these projects I've done for people kind of off the, you know, behind the scenes, and it's taken me actually days to download that data. But in this case, when I can download it, I usually get, I mean, it's done, like you can see, a few clicks and you get your data set. And I'm sure it's here somewhere on my desktop. I'm just not seeing it. So I don't know. I have oh, here we go. I found it. It's here. Here we go. Sorry about that. I mean, I'm going to say I've never had that problem happen before, ever, that we didn't get the data. So.
Andy, I think you have to do, oh, there it is. I was going to say screen share.
I just have to, oops. Hold on a minute. It went to my other screen. Let's see if I, let's see if I close this. Diagnosis, here we go. I'm messing around here because I'm closing my laptop so I can see it. And I think by doing that,
So Andy, you have to stop sharing
There we
one
go.
screen and reshare another, but we're out of time.
Right. Okay.
And I know I have another meeting to attend too, but I wanted to see if there was if there were any burning questions that you might be available to stay for, even though I kind of have to hop off and go on to something else. But this has been great. It helps so much to see it, you know. Now I get it.
Now you get it. Okay.
Now
Yeah.
I got
I know
it.
people keep saying, you know, who's going to run this for me? And I'm like, I'm not going to run it for you. You're going to run it yourself, because we've tried to make it easy enough so that it can be run by yourself, right?
Yes.
So, and that's the goal. That
so
is the main
Drenna,
goal.
maybe if I don't know, did Drenna leave? No, there she is.
I'm here.
If people have questions, they can either just direct them to Andy, myself, Rose. That's fine. And if we find there's lots of questions or a need for follow-up, we're happy to come and talk again at another time.
There we go. There's the data. Okay.
Gotcha.
So.
Okay, this was super.
So anyway, so that's Nell.
Right.
I think there are questions in the chat here too.
Yeah, we've been, Vicki and I have been answering them. But
okay.
I think I was on mute when I suggested, you know, please just send any of us, Andy, Judy, Rose, your questions. We'll be happy to answer them. And if there's a lot of them, maybe we'll suggest to Drenna that we come back for 30 minutes at a meeting and go over all the questions.
Yeah, there's a Project Nell email also that you can send to. It's on the website. So, I think my computer is not happy with all the things I have open on my desktop. Anyway.
Well,
thank you very much
for your time today. We appreciate it.
Thank you for having us.
Bye.
All righty. See you. Bye-bye.